One of the things that was a big advantage to CCTC was that myself and other members of the CCTC team were heavily involved in the leadership across the provider system in Philadelphia. So we were able to go out and talk a lot to folks about how much of an impact Sanctuary and this approach was having on the work that we do. Why it was mattering to us. It was far beyond the work that we do just with the families and the children, but also how it began to impact how we worked with each other, how we thought about the work, and how we even did business. It was really critical because I believe that one of the roles that we played in the system was that we promoted this kind of thinking amongst other providers. And then over time, as they received the opportunity to move forward with investing in a trauma-informed model, they already had received a lot of positive praise from us in terms of how the work impacted them.
What we did to roll out the program and roll out the sanctuary model at the Red Shield was, following the staff receiving the training, we had 12 weeks of additional training where we included a group of our residents. So they learned all about the values of sanctuary, about self, about what it means to be trauma-informed, about the nature of trauma, so that we could eventually engage more and more families in learning the model while we implemented some of the tools of sanctuary, like the community meeting, morning meetings, red flag reviews, so that it all sort of rolled out at the same time.
Dr. Rich and Dr. Bloom came with me on separate occasions to the National Advocacy Center in South Carolina, which is where we train all Department of Justice lawyers and other lawyers from around the country about various things, generally dealing with prosecution or other aspects of what we do in the Department of Justice. But they did presentations, that is, Dr. Rich and Dr. Bloom separately did presentations to an audience of prosecutors and other people from the Department of Justice. And I will tell you that I introduced their presentations as the most important training they will ever have. In addition, Dr. Bloom and I made a video, and it was an opportunity to introduce the subject and make a record of it. It was actually about a 2-hour video, which is now online for anyone in the Department of Justice to access. So it's Sandy Bloom, nuts and bolts, all about trauma-informed care. It's a video for everyone to see. I chime in because, again, why am I such an advocate for trauma-informed care? Well, I tried to explain it. And what I tried to explain was, when you look at a place like Philadelphia, which has had, over 4,500 murders since 9/11, and has had well over 20,000 people shot since 9/11, and that doesn't include the number of suicides and other, assaults that we see all the time, I felt it was incumbent upon people in law enforcement to understand what trauma is, what is the long-term impact of trauma, what is the neurological impact of trauma, and what can we do to reverse trauma. In addition, what we've done is we've begun training Philadelphia police officers. So working with the Healing Hurt People folks and Dr. Joel Fine, Dr. Stephen Berkowitz, we have started a pilot program to train Philadelphia police officers about trauma. And because, again, it just makes so much sense to me that if you're exposed to trauma, whether you are living in the community or you are serving the people in the community, you are going to be exposed to things that could traumatize you. And in fact, we're finding that a lot of the police have suffered severe amounts of, let's say, stress that includes, for some people, trauma, their PTSD. So the whole idea of hyperarousal, it's no different for a police officer. I shouldn't say it's no different, but it's consistent with what soldiers in war experience. So we've begun that process. And at the same time, we're doing a whole project, and this has never been done before, as funded by the Department of Justice. We received a grant to provide trauma-informed care training to folks within Philadelphia, specifically the Strawberry Mansion community. And Dr. Bloom is involved in that. It's been a phenomenally educational experience for me and for everyone involved, because what we're doing is we're taking a group of people who have lived in a totally underserved community that is very poor, has suffered vast amounts of violence and really neglect over generations. It's been again, a phenomenally educational experience, and we are now starting to build it out to a larger part of the community. My goal in all of this is to not only educate this community, but also at the same time educate the police, so that we're essentially sensitizing them to what they have both been through, both groups, and to bring them together as one. To me, this is the ultimate of community policing. This is bringing the police and the community together so there's a shared understanding of what's really going on. So it's not as if, well, everyone who lives across this street is a bad person. It's what happened. And also what's happened to the police in their experiences dealing with the violence that's going on in that community.
So I had the opportunity to craft a clinic for young men, not young African American men, not young victims of violence, but young men who tend not to make the transition from pediatrics or adolescent medicine to adult medicine, and created a special portal, a special way of entering the healthcare system where we could pay attention to their trauma, have a community health worker there, come with a sense of respect and a sense of empathy for their circumstances without judgment. And so that was a way of using the system to change. Now, I will tell you, the limitation was that that work in itself didn't change the whole system. It became what you might think of as a workaround to the larger toxic system. And so when I had the opportunity to work with the health department, we began to think more intentionally about how do you prepare institutions to care for young people? What kind of training do providers need? What kinds of supports are there? And that's when I began to learn about work like Sandy Bloom's sanctuary model. And when I got to Philadelphia, the work that my colleague Ted Corbin's leading, that really began to think about larger hospital-based systems and how we could transform the care that young people get.
I was given the opportunity to spend some money to help childcare programs become more parent-friendly, to change that culture a little bit, and then also to see what we could do around the social-emotional work. And after learning about Dr. Bruce Perry's work and reading his book, Boy Raised as a Dog, and following him around and seeing his presentations, we were very impressed with his neurosequential model of therapeutics. To me, it was something that we could use, a tool that we could use, because it assessed trauma for children, even if the child was just 1 year old. We could figure out where in the lower brain there might have been some issues around normal development. And so what we were able to do was fund 20 scholarships for local clinicians, people from Bucks County at the Warwick House, St. Gabe's Hall. We got a bunch of clinicians together, and we started something called the Neurosequential Model of Therapeutics Philadelphia cohort. And we met every other week. We're still meeting because we started a second cohort of clinicians really trying to understand this tool, how to use it and assess and come up with a treatment plan for children. But then what's also really exciting about this tool and why I thought it would be great for early childhood was because it would inform curriculum. And so if we know, we all hear about 90% of the brain growing, before the age of 5. But what specifically are they working on? Well, it's sensory integration and sensory regulation. And we have all of those ingredients in a childcare classroom, but we're not using them in a brain-friendly way. It's random curriculum. We do gross motor for children and fine motor, but nothing is really making sense in terms of how the brain grows in that development. So we're still working on how we translate some of the concepts and framework around the neurosequential model of therapeutics and how we can inform curriculum in the early childhood environment.
I have the honor of leading something called the Violence Prevention Initiative. And that's kind of a whole hospital violence prevention effort that works at multiple levels to prevent violence in the community and in our schools and really in our medical system. Our entire training core is based around trauma-informed care and teaching our hospital staff, personnel, everybody who comes in contact with a kid or a family about the concepts of trauma. And that can range from just basic Trauma 101 to truly training people in CFTSI and other psychological, interventions that can deeply affect a family. One of the challenges is that every time we teach this, we get another person who's at that training who wants us to train another group. So we're doing this actually by request right now, and we've also now established what's called a learning link, which is something that you can go online and literally in 15 minutes get the basics of trauma that will be available and possibly even mandatory for our staff as part of their every year re-upping of their modules that they have to take for being a staff member at CHOP.